Hi, this is Dr. Lenore Coleman. So glad to have you here for your health. We're here on Saturdays at 1 o'clock, and we've been talking about health disparities. And this is an issue that is really affecting African Americans and Latino populations, all people of color. And so I wanted to focus in on talking to Dr. Daniel Sarpong. Now, Dr. Sarpong is the director of the Center of Health Disparities at the Xavier College of Pharmacy. And he was in charge of an amazing conference, 14 years, the 14th Annual Health Disparities Conference. It was actually in New Orleans, and we were able to have 2 days of nonstop lectures. We did it on Zoom. This is the first time we did it on Zoom, the whole conference, and I was really pretty impressed. We pulled it off. This Zoom is not easy, I'm telling you. And so we pulled it off. I actually spoke. I gave a 15-minute presentation on health disparities and leveraging the technology to improve care within our healthcare systems. And so I called up Dr. Sarpong last minute and said, "Hey, Dr. Sarpong, can you come?" Hey, so I just wanted to thank you, Dr. Sarpong, for this last minute invitation
You're
for your
welcome.
health. How are you doing today?
Doing wonderful, and thanks to having me. I appreciate your participation. I think your presentation was dynamic. Wish we had more time for you to expound on what you presented, so I think we'll look for opportunities to make that happen.
Yeah. I called you up and said, "Hey, I want to do it again so I can stretch and
Yeah,
have at least an hour and a half because this topic
right.
deserves an hour and a half." But I wanted to just spotlight the conference. I want you to talk about the center, what you guys are doing at the center. You're in Ground Zero. You're in New Orleans, all right. And
Right,
whenever you talk about health disparities, we learn a lot from the place where Katrina happened, right? And
right,
and you're
right,
still recovering from Katrina. People think everything's 100%, but there's still a lot of people who are still rebuilding in New
right.
Orleans.
That's right.
So I just wanted to kind of just introduce yourself. Tell us a little bit about who you are. Tell us about the center, and then let's just talk about the conference and what we both learned from those presentations.
Okay, well, thanks for the opportunity. I'm Daniel Sarpon, a biostatistician by training. I currently direct the Center for Minority Health and Health Disparities Research and Education Center, which is under the College of Pharmacy at Xavier University of Louisiana. Basically, my career has been quite interesting. I was at Xavier before on the faculty teaching biostatistics in the College of Pharmacy. Then I was blessed and had the opportunity to go to Jackson to work with the Jackson Heart Study at the onset of the study, and started off as a senior biostatistician, and then later became the director of the coordinating center, which at the time was under Jackson State. I ran the data coordinating center for 4 years, and then later on, after 10 years, I went to work with another coordinating center at Jackson State. And then in 2013, I came back to Xavier to work with the Health Disparities Center. So Xavier is one of the few institutions that have been blessed to have the endowment from NIMHD to be able to create the infrastructure to help us to address and mitigate health disparities. So our focus initially was in the areas of cancer, diabetes, and also asthma. And so we've had projects in the past. We've been able to leverage the center's capacity and Xavier's role in the community in terms of building a trusted relationship with the community through health fairs and various activities through the pharmacy program. We've established a number of relationships with, community pharmacies, with the retail outlets like CVS, Walgreens, and also with some of the QHCs. and the major hospitals in the city. So we've been able to leverage that. More recently, we've been very involved in the COVID activities. At the onset of COVID, between March and I think July, we did a number of forums, open forums, where we invited community because we wanted to create a safe space for people to express themselves and for us to truly understand the effect of COVID-19, particularly after people had gone through the traumatic experience of Katrina. So we did a number of those series, and I think that groundwork also allowed us to be able to team up with Tulane University to be one of the to be the recipients of the Louisiana SEAL project, which is funded by NIH, a project that is looking at involving community to fight against COVID. And so we've been laboring in the vineyard trying to bring the information to folks, educate ourselves and the community at large about, the importance of masking up, creating social distance, and then also washing hands and, adhering to some of the basic hygiene that we should all be practicing even before
Exactly.
COVID,
Exactly.
So that's what we've been doing, but also giving community a safe space for community to educate researchers and the scientists and the practitioners as to the real issues that are going on. So we've learned a lot from that experience, and through the center also, we're involved in the Louisiana Clinical and Translation Science, where we provide leadership for the community engagement. And then I also direct the community engagement for our RCMI Cancer Center.
Okay.
So we have our hands full, and
Yes, you do.
but we're still doing the best we can because there's a lot of work to be done. I always say that, we've made great strides in terms of health disparities, but COVID-19 has taught us that we still have ways to go, and it just blew the lid off the disparities that we knew existed and we needed to still work. So
Yep,
hopefully we'll all
exactly.
come together.
So, you said a couple things, and I just wanted to highlight. So,
Mm,
the Jackson Heart Study was one of
right,
the longest running NIH funded studies looking at disparities in heart disease of predominantly African Americans.
right.
And
All African Americans, yeah.
all African Americans. And you were the coordinating center for this study. So a lot of
Right,
people don't know what
right,
that means. What that means is that all the data and all the programs and all of the outcomes and all the publications that came out of that study came through that coordinating center. So
right.
your expertise then is now at Xavier College of
Right,
Pharmacy. So you're talking
right,
about bringing this wealth of research capability that is now housed at Xavier College of Pharmacy. And I wanted to give you that plug because, they're always talking about we can't find qualified researchers. And we don't want to give the money necessarily to HBCUs because they don't have the infrastructure to be able to carry out various research. But that's
right,
not true at
right,
Xavier College of
right.
Pharmacy, the Center for Health Disparities, because they have you,
Mm.
right?
Well, I think they have more than just me, but
Well,
thanks
no,
for the, yeah,
we know that leadership comes from the top. And so
mm,
you and Dr. Kathleen Kennedy, I'm giving her a shout out.
mm,
She she was a classmate of mine at the
mm,
UC San Francisco, PharmD, a wealth of experience. She's been dean there for a number of years. Dr.
right,
Francis, everybody knows that name. He's retired now, but
right,
Xavier still has one of the best undergraduate program for preparing undergraduates to go to medical school, and they still
right,
have some of the best interest rates entrance rates of students that actually go from undergrad into medical school. So I just
Right.
really, whenever I get an opportunity to talk about my HBCUs, I have to do it, Dr. Sarpong. I'm sorry, but I got to
Well,
talk
no, it's
about it.
okay. We got to learn how to tell our story,
Yes,
and
yes.
tell it well. So
And tell
yeah.
it well,
Okay.
and tell it well.
Mm.
So yeah, so COVID-19 really they took the Band-Aid off, right? It peeled back
Right,
some of
right.
the onion, and what they found
Mm,
underneath those few top layers of that onion was a whole lot of diabetes and
mm,
hypertension and obesity and
right,
COPD uncontrolled. Now,
right.
you and I know, because we read the literature,
Mm,
that we know how to take care of these disease states.
right, yeah.
And that pharmacists are a huge part of that. Yet we still are not utilizing our pharmacists to the maximum ability to help
Right,
with getting patients on the right medicines and also taking their medications. So I
right,
really
yeah.
encourage our listening audience
Mm,
to understand that you have
right,
pharmacists in your cities, in your communities. Some of you have pharmacy schools in your cities, in
right.
your communities, and you need to be asking your pharmacist and using them to be able to help you with your medicines.
Right, and that definitely needs to be a transformation in terms of the role of pharmacy and in the whole care system, care delivery system, and even public health. Because a person is likely to encounter a pharmacist in their community than a healthcare provider or a healthcare provider, since some folks don't have designated healthcare providers. So I think there needs to be a paradigm shift
Yes, I agree.
in terms of that. Yeah.
Yeah, yeah. We need to be just.
Mm,
I would like to re-engineer the whole system,
mm,
and I have the idea on how to be able to do that. Okay, because I've been at this for 40 years. So it's not a
mm,
matter of we don't know how to do it. It's a matter
right,
that it requires funding to do it. So I'm hoping
right,
with this new administration and with the fact that there seems to be an interest in addressing some of these disparities among the
right,
new administration, that maybe funding some dollars will come to places like
mm,
Howard University, Xavier University, Florida A&M. These are places that have been around for years, who have the
right,
faculty and the infrastructure. University of South Florida also, these are people that have been in the
yeah,
game for a long time and could lay
right,
things on the ground. And you said something really important. You said you're a trusted part of the community,
right.
and that's critical.
Right, it is, and we have to be always reminded. And I'll give you an instance, and that really shaped. I mean, I was always mindful, but when I was at Jackson Heart Study, we had a seminar, and Dr. Charmaine Royal, who's now at Duke, she was at Howard at the time. She's more of a social ethics person in genetics. So she gave a talk, and one of the leaders in the community who was a participant in the study was also a participant in the ERIC study, which is the precursor to Jackson Heart Study. And she asked her a question, and she said, were you all troubled by everything we were talking about in genetics? And she said, no. And at the time, the PI, Dr. Herman Taylor, was also standing around. We were all standing talking after the presentation. And she said something that was very profound. And what she said was, I'm not worried because I know these people would do right by us. And for that moment, every time I had to make a decision, I had to balance discovery of science with the trust the community had
Right.
in us. So we cannot violate that trust. It's very important, and we have to respect that.
Yeah.
So that has really guided and informed the work that I do. That I don't just take that for granted, because if folks trust us, we got to uphold that trust. We should be able to balance scientific discovery with creating a trusted relationship with community.
Exactly, exactly. Because I really just think, in fact, I did an episode when COVID first came out, and there was all this discussion about Tuskegee experiment and what that means, and that's why African Americans don't participate in research. And I did a whole show on that with Dr. Gavin, James Gavin, and we
Right,
both, as you know, we do minority recruitment for clinical trials. We've done that in the past, and so we really got knee deep in that whole
right,
understanding of hesitancy for patients participating in research, and also the hesitancy for taking the vaccines. So
right,
all sort of all mixed up together. And what we found is that, if you have trusted institutions and trusted people like Healing Our Village and various other organizations that are not going to violate that trust, then you can
right,
feel comfortable that if we're associated with it, we've checked it out, right? We're not going to have you in a
right,
study where we know that
right,
there's a chance that there's an increased risk of adverse events in African Americans versus Caucasians. That's not what we're going to be involved in. So I think
right,
that trust is so important
right.
and goes a
It
long
is.
way. So the topic today for your health was, why are black folks still dying? That's why I called it. Why are black folks still
Still
dying?
done.
And COVID-19 showed us that clearly. If you look at the statistics of who was dying, not who got it,
Right,
but who
right,
died, it was the black folks and Latino
right.
folks, right? So the question is why are black folks still dying? Why are there still health disparities in 2021? I wanted to kind of get your perspective on that and talk about that for a minute.
Well, there are a couple ways, and this is a very interesting question. And I think, we sometimes miss things because of the focus, even in science. So earlier on, when, we were talking about the disparities and looking at the differences in mortality, what I say is that the virus is not discriminatory. It doesn't know if you're black, white, Asian, Hispanic. It doesn't know that. But I think because people of color are generally burdened with these chronic diseases, if you put race aside, you realize that the main drivers of the mortality was hypertension, diabetes, obesity, heart disease, pulmonary um, maybe disease, and so on and so forth. And then then comes the cancers.
Right,
So the main drivers were the chronic diseases, and most of them were heart related.
right,
Who is most affected by these conditions and not well managed? The people of color.
right,
Some of it is structural in terms of, not having good access to care, good food, you have food insecurities and so on and so forth. And economics play a lot of role in it. So what it has taught us, and now has become the most popular thing, and it was popular before COVID, is the social determinants of health.
right,
At one point, we didn't want to deal with the social determinants of health because we said there was the soft science and couldn't measure it like you can measure blood pressure or A1C and so on and so forth. But human beings are not just fluid and cells, and they have the psychosocial dimension and the spiritual dimension to ourselves. So we definitely have to take those things into consideration. And some of these injustices and inequalities in our social systems have created chronic stress. And we know that these psychosocial stresses do have a negative impact on the body. Some have studied and call it the allostatic load and so on and so forth. So we definitely know that these things exist. It's just that maybe as a nation, we don't have the political will
right.
to address it.
Yeah, yeah,
So therefore, we kind of use the bandage approach. And then we also shift the responsibility to the person. But I think there needs to be a balance between personal responsibility and societal
yeah. I
responsibility.
agree.
There has to be a balance between those two things. So an example I like to give is that there's some people who cannot cook decent meals. They eat outside because they have 2 and 3 jobs. They can't go in between jobs and go home and cook before they go to their next job. But we can regulate what goes into those food preparations.
Right.
But if we don't pass policies and put infrastructures in place where these foods are prepared in a way that they're healthy, then the person is at the, no matter what they do, they're not going to be as healthy as they could be.
Right.
If they have to give up work and they're not privileged enough to be able to have sick leave and days off or vacations, and the hourly workers, they can go sit in a hospital or clinic for a whole day and miss a whole job. So they're only going to go when they're real, real sick.
Right.
So there are all these things that are important. But come back to your question. See, if you have more blackfishes in a pond and the pond is poison, who do you think would die the most?
The black fish.
The black fish, because they're in greater numbers. So the virus affected more black folks. People didn't look at it, but I early on looked at what they call the case fatality. And I looked at the data because the data was available for Mississippi on the website. And the case fatality for blacks and whites was the same. So they
Okay.
were dying at the same rate when they were infected. It's just that more of us were affected, so that more of us would die. So if you just look at the percentage of mortality by race, people of color were disproportionately affected.
Right.
But in terms of the case mortality, it was almost neck to neck.
Okay.
So
Gotcha.
therefore, it's just showing that if you have more people being affected for whatever reason, because they don't live in areas where they can social distance. You have multi-generational people living in the same household, 4 or 5 people living in one room. How are they going to do social distancing?
Right.
And if one gets infected, they can't give a whole room to one person and quarantine that one person.
Right.
So there are a lot of structural things, and so people take their chances. So if more of us got affected and you have the same case fatality rate, our numbers are going to be more in terms of death. Because if you
Right.
take 5% of 1,000, 5% of 100, yeah, the 5% of 1,000 is going to be more.
Right. Right.
So I think we need to look at the data, and then also to be very careful that we don't victimize or stigmatize the victim,
Right.
by saying, oh, this is a black disease, or you're black more. It's true that black folks have been affected more, but why are they affected more?
Right. 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 Right.
You
Right.
know,
So, so I way back, I've been doing this 40 years. So I was all into the whole 2010, Healthy People 2010. And by 2020, we were going to affect these social determinants of health and we were going to change them. And so the audience knows what we're talking about. When you're talking about social determinants, you're talking about housing. You're talking about
you're right,
poverty. You're talking about
right,
access not only to health care, but to good health care, all right, to
right,
efficient, quality health care.
right,
We're talking about good education, good
right,
schools. We're talking about
right,
safe environments, not
right,
being able to go to the park because they're selling drugs there. So you can't just have your kids.
right,
When I was young, I
yeah,
did my chores, got on my bike, said bye, mama, and I was gone. She didn't have any idea
right,
where I was playing. Now, I told her I was going to be at the park or I was going to my grandma's house, but she didn't. There wasn't no
right,
cell phones. She couldn't check on me.
right,
There wasn't no GPS. I just had to be back
right,
before dark. Now, that's some trust,
right,
right? Think about that. My mama knew I
right.
was
That's
coming
it.
back, right?
Right, right. But today you can't assume that would be the case. Yeah,
No,
yeah,
no. So all of these are the social determinants. When we go to our grocery stores,
mm,
is there a grocery
mm,
store? Or are we doing
mm,
community stores? And in those community
yeah,
stores, how is the produce? Is it fresh?
right,
Do they have good quality meats and fish, etc.?
right,
So those
right,
are the social determinants. And we've been talking to
mm,
the government and our city
mm,
and local
mm,
folks to try to change
right,
the dynamics in our zip codes. And we've made
right,
some changes. Now, don't get me wrong. There
right,
has been some
right,
some structural improvements in the
right,
community, but not enough to
right,
offset the amount of chronic disease.
right. That's it.
So that's
But
the
I also
problem.
think that, I think the other thing also is that I think that we've done a lot of work to create evidence. but we haven't done a good job in translating the evidence so that it actually brings about modification in
Right.
behavior and
Right.
lifestyle.
Right.
And I think that's our next frontier
That's the
is
next
how do
frontier.
we take all this knowledge? You know, it's almost like the Christian who reads the Bible every day, but then when they get in a problem and they forget the verses they need to kind of keep them going,
Yep. Exactly.
you know. So
Like this too shall pass.
it's right, right, right. You see, if you had two verses that you know very well and that keeps you through and keeps you going, it's better than knowing 100 verses, but you can't apply none of them when you're in time of need, you know. So that's all I'm saying,
Yeah.
that we
Exactly.
need to do a better job in helping folks understand and put it in a way that they understand in a language which is culturally appropriate, that resonates with them and hits that emotional button to cause change.
Yes.
People know these things intellectually.
Right.
They're not just doing it because it doesn't resonate with them emotionally.
Right, 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 right. You know, I am I'm working with patients. I call them my 300 club.
Mm,
So I'm working with patients
okay.
who weigh 300 pounds or more.
Mm, yeah.
Now, you know what? Those folks have mirrors in their house, or if they don't have any
Right.
mirrors in their house, when they go out of their house, they walk by a window, and
Right.
they know that they didn't used to look the way they're looking now. They know that, right?
Right.
These
Right. Right.
and listen, they don't fly because they can't
Right.
fit in the seat, or
Right.
they have to get that extra extension seat belt for
Right.
this for the
Right.
flight, right? Okay,
Right.
so they
Right.
know that they are bigger than they're supposed to be, but yet, because of a lot of factors, they're not able to change their behavior to get back
Right.
down. The gentleman that I was helping over the last few weeks with his insulin therapy, he says that when he goes to the doctor's office, the people in the office, the people waiting in the office, the nurses, and even the doctors look at him with disgust because and he can feel it. He can feel
Right.
that
Right.
they're
Yeah.
looking at him and making a judgment about how did you get so big? And what kind of
Yeah.
person are you to let yourself get that big? So what does he do? Doesn't go to the doctor. So then therefore it's a
Right.
little hard to get a refill on your prescriptions if you decide that
Right.
you don't want to have that kind of guilt and treatment
Yeah.
from our healthcare. So these are big problems. These are profound problems, right? And you're
Right.
right. The next frontier is us trying to figure out how we're going to make it really simple for people to
Right.
make small changes that can get
Right.
them on the road to living a healthier life, right?
Right.
So
Right.
that was what your conference was about. The conference was
Right.
excellent. Again, 14 years of this. I wanted to do this with you because I want you to take this and I want you to send it out to all of your Xavier alumni so we can tell
Yeah.
them what they missed. All right, because
Right.
they missed
Definitely.
an amazing conference. So I wanted to take
Right.
just a few minutes so for you to you're doing sort of a debrief, right? You're telling, after in
Okay.
a retrospect what you learned, what happened, so that you can let our audience know, to be there for the 15th annual, which by the way should be in
Right.
person, right?
Right. It should be in person.
And
Right.
I would
Yeah.
love it to be so big that it would have to be in one of your big civic centers, okay? Because there's so
We're
many
working.
people
We're
coming.
working on it. Yeah, we're working on it.
Yeah,
Yeah.
yeah. So talk to me about it was a 2-day program. Tell us a little bit about it
Right.
and what day one, day two, and what happened during those days.
So basically, the title of the theme of the conference was Evidence of Personal and Societal Determinants to Achieve Health Equity as a Public Health Practice. So again, it goes back to my previous comment about the need to have a balance between personal and social responsibilities, because our inequalities is both on a personal and on a societal level. And we need to find a way to bring some balance between those two pillars in terms of addressing health equity. So we started off by saying, and since we're in the era of COVID on day one, to say, how has COVID really exacerbated the existing racial and ethnic and social economic disparities in health. So we were fortunate enough to have Dr. Stewart, who is now at the University of Tennessee, and Dr. Elvin Price, who is at Virginia Commonwealth. And they did a phenomenal job with the presentation.
Yes.
Dr. Stewart came off from the mental health, behavior health arena and really highlighted the impact of COVID on our society in terms of behavior and mental health, and that we really need to take a look at it and to be able to examine some of the things that are going on. I mean, she did a phenomenal job in putting that in perspective. Dr. Price, who is a pharmacist by training and also a researcher at Commonwealth University, brought in also the experiences of his work through his university and their relationship with the community and how they were addressing the issues of COVID, making sure people had the information. They've been very active in their community because they have a number of housing developments in that community, and they take the care to the people.
I love
And
it.
so basically, it's more of you meet the people where they are,
Right.
and talked about some of the structural changes. And also, I really commented on the fact that, NIH put out this publication where we were talking about the fact that ethnic minority, he called it the minoritized population. I thought that was a cute phraseology that he
Yeah.
had come up with. But people of color who are researchers most likely would not get funding based on the topic they were meant to study.
Mm-hmm.
And he really drove that point and really looked at some of the, theoretical constructs and models and frameworks that are out there that people have proposed. And the fact that if we use those kinds of models, we're going to miss the needs in addressing the health needs of our community. And so there is a need to have a paradigm shift on that.
Right.
So
I
I think he
agree.
did a very good job laying it out. And the need that we really need minority investigators or people of color, because even if they don't live in the community now, they have family members who live in those
Yes, they do.
communities that are
Yes.
disproportionately affected, or they grew up in a similar environment
Right.
and community, so they could relate to some of these things. And so I think it's important to actively involve people of color. And so for folks, the gatekeepers, to not fund these things because of topic, may be the reason why we haven't moved the needle
Right.
much more than we need to, because, Einstein said that if you keep asking the same question and expect different results, that's insanity.
Right.
So if we're not making as much progress, then maybe we need to frame the question differently, or
Yeah.
we have to do something different.
Yes.
If
Exactly.
you've been broke the last 5 years and you keep doing the same thing you did the last 5 years, you're going to be broke the next 5 years.
Pretty simple.
You shouldn't expect, right, you shouldn't expect that same practice and behavior is going to miraculously all of a sudden make you rich,
Right. Exactly.
so. And they also say that if you want to be rich, you don't go and talk to your broke brother-in-law, because the only advice he can give you is how to be broke.
Exactly.
So if we really want to understand what's going on, we have to talk to the people who are experiencing it. And
Exactly.
that's why
And
the relationship.
yeah, the other thing
Go
I was going
ahead.
to mention is not only is the funding not been given because they don't like the research topic, but even if they do give the money, it's not the $1 million grants. It's not the
Right.
$1 million for 5 years. It's the $250,000 or the $500,000 for 5 years, which at the end of the day is just not enough money to be able to
Right.
even do the deep dive, because these are more difficult study questions that one has to be
Right.
done. That was why the Jackson Heart study I thought was phenomenal, because it was well funded. in terms,
Well,
I
it
mean,
was very rough.
overall, as opposed to
Right.
other ones since then, right? So we need to get back to that level of funding coming from the NIH institutes if they really want to solve this problem. Yeah, so I thought the COVID-19 was really good. And then I systems integration was the one that I did, talking about the healthcare
Right.
system.
Yeah.
Yeah, yeah.
Right.
And I
Yes.
thought that was interesting, and we talked about just again a paradigm shift on how do we take care of
Yeah.
people, where the failures are with the way clinicians are taking care of patients, the way the hospital systems are taking care of patients, and then what can pharmacists do to change the dynamic that we're seeing every day. So I really
Yeah.
enjoyed doing that segment, talking about leveraging and
Yeah.
improving health equity in healthcare
Yeah.
systems. Yeah.
Yeah. And Dr. Hoover also shared with us some of the work that the Gates, Bill and Melinda Gates Foundation is doing on the global front. And I think the Ethiopia example was an excellent one. So, but I think even as a very well-developed nation, there's a lot that we can learn from some of the developing nations. And so we need to take, because some of our communities, if they weren't if their address was in the United States, it would be a developing community or a developing country.
Yeah,
So
exactly.
maybe some of these models that have worked in low resource environments, and again, maybe we should stop doing these labels. I mean, a lower resource and communities, a low resource community, whether it's in the US, in Europe, or in Africa, it's still low resource.
Right.
So models that work in other low resource communities could be adopted into these environments that we can get them from going from low resource to high resource environment.
Right.
So I think, yeah, those things are things that we also need to really bear in mind.
Let me just
Um,
throw this out there. And Daniel, tell the audience where you hail from originally, your family.
I'm originally from Ghana. Yeah.
Okay, so I wanted to get that
Yeah.
out there because Healing Our Village is a
Mm,
global company.
mm,
I'm really
right.
focused on global. I want to
Mm,
say something about that because this is a point
yeah.
that I always wanted to
Mm,
stress.
mm,
One of those countries, those African countries, and
mm,
I've been to several. I've met people
mm,
from many, and one thing
yeah.
that really struck me is that they value education.
Yeah.
When I
It's a
took
great
my
equalizer.
It's a great equalizer. And when I wrote a book on diabetes, and I've been trying to sell the book here for, I'm up to my third edition. Very few copies sold here in the United States. When I went to Nigeria and I took a suitcase full of books, because I was the keynote speaker at the meeting, I sold out in 5 minutes. They were angry because I didn't bring more
You
books.
know, you didn't bring enough,
I
right?
didn't
Right.
bring
Yeah.
enough books. And I said, well, people in the
Right.
United States don't read. We want everything on
Yeah.
our phones, social media. We're not
Right.
reading.
Mm,
So I think
mm,
that you were talking about personal responsibility. Part of that is
right.
is, is education and
Education.
knowledge
Right.
and making sure
Right.
that you know what you need to
Right.
do so you
Right.
can live healthy. So I
Right.
think that that's important.
Mm,
And I agree with you. Those
mm,
low resource countries, if we could bring some of the
mm,
things they're doing to our
right.
places like Detroit
Right.
and Harlem and
Mm,
Watts. I mean, we have low resource communities.
right. Yeah.
Yeah, I
Right.
agree. I
Yeah.
agree. Excellent, excellent.
And
So then now
we
session three was on education, industry, and social justice, right? It was about
right,
workforce.
right, right, workforce. And I think the whole point, I think the two speakers touched on, one focused more on the criminal justice system and the fact that, there are a lot of inequalities over there, and the fact that, even people have gone to the extent of talking about building jails for people with mental illness. I mean, so this whole idea of criminalizing everything, whether
Yes.
it's having mental health or substance abuse disorder, so that we really need to step back and really rethink this whole criminal justice system. But also too is that, the need to have a diverse workforce, I think it's very important.
Yeah.
Sometimes people don't understand folks because they don't culturally have they don't have a sense of reference. And then, I always say that, when you walk into an event and it's a large event and you don't know anybody, what do we typically do? We scan the room and we gravitate to one side of the room because we feel we'll be comfortable with the people that we see in that section of the room.
Right.
And maybe we could start a conversation. Eventually, you might work your way through the entire room, but somehow innate and within yourself, there's this bias system, which in a way is good, and in some ways is bad if you oppress somebody with it. But that is what gives us the ability to say, okay, I feel comfortable. So, having people who look like you, people who understand you, because the example you gave earlier about this guy not going to the doctor because he's looked upon in a negative way, and who wants to be humiliated?
Yeah.
He already has a health problem that he's trying to fix,
Right.
and they're not making it any better. So there's a tendency to avoid unless you desperately need the help.
Right.
So I think that was the point that was made under that section, the need for workforce diversity. And we've done a good job in this nation, but we still got a long ways to go. It's
Yeah. Go,
all
yeah. Long
I
ways to
think
go.
it comes down to. So most of what we're saying, we're not saying that we have not made any progress. It's just that the progress has not been able to address the issues that we're faced with, and we need to continue to do more in certain
Yeah.
segments of our society.
Exactly, exactly. So that was our three sessions for
Mhm.
the Wednesday, and then you did the town hall and the poster sessions. So now
Right.
Thursday, there was the young investigator lecture. But listen, let's take a break
Mm,
before we get into day two. So hold on, don't go anywhere. We're just going to take a short
okay.
break. My audience, get up, step in place,
Mm,
go get yourself some water or some tea,
right.
and come on back because we're going to talk about
Mm,
the next day, which was also exciting. Thanks.
mm.
Epigallocatechin gallate, superoxide dismutase, glutathione peroxidase. Now, those are names you probably aren't familiar with, but you should be. Those are antioxidants known to fight free radicals. In fact, did you know that some viruses are actually alcohol resistant? One major study showed that by adding the epigallocatechins from green tea, it killed the virus on contact. Please allow me to introduce myself. My name is Mark Johnson. I'm here to share with you an exciting new, technologically advanced, patent pending green tea hand sanitizing wash from Handout Protection. Now, this is not your typical hand gel designed to just smear all over your hand. This is a hand washing sanitizer to cover your entire hand, both the front and back of your hand, in between your fingers and your wrist. This is a non-sticky sanitizing hand wash designed for convenience to take with you in your purse, pocket, or carry in your lunchbox. As Dr. Josh Ridge has stated, what goes on your body goes into your body. That is why we choose only the highest FDA-compliant ingredients, such as 75% isopropyl alcohol and organic green tea brewed with alkaline water. The only way to protect yourself and your family is to always carry a disposable package of Handout with you. This may be the only handout you ever need.
Hi there, hi there. Welcome back to For Your Health, and we're here today talking about health disparities. The topic I called it today are why are black folks still dying? And we have with us Dr. Daniel Sarpong, who is director of the Center for Health Disparities and Minority Health at the Xavier College of Pharmacy. I gave a shout out earlier to the dean there, Kathleen Kennedy, Dr. Kennedy, and her and Dr. Sarpong have been at this for a very long time. We're actually doing a sort of a debrief on the wonderful Health Disparities Conference, 14 years of doing this Disparities Conference that happened this week. So if you didn't tune in, folks, you missed it. because it was really good. It is the preeminent health disparities conference in the country. And so I just wanted to have, Dr. Sarpong sort of, review what you missed. And so we already have talked about day one. So Dr. Sarpong, let's jump into day two. And the first was the John Ruffin Young Investigator Lecture, which I thought was interesting.
Right. Yeah, the young lady talked about Chi Chi Smith, who is at the health department in Arkansas, who's also a doctoral student with Walden University. Really talked about her work and the involvement of the barbershop model of really addressing health needs and hairstylists. So she shared some of the good work that they're doing. And she even made the point that she sees a hairstylist more often than she sees a haircut provider. And so there have been a lot of models, and I think Dr. Stephen Thomas over at, I think he's in Pennsylvania, I think.
Yeah, University of Maryland.
Maryland, sorry, University
Yeah.
of Maryland, whose work, did some of the work in with the barbershop concept and taking health to where people are and engaging folks. So I think that was a really excellent presentation. And just to add to it, I think about 6 years or so ago, we created the John Ruffin Health Disparities Lecture Series. And we thought that this was to honor all the work that he had done in addressing health disparities, having worked with NIH for 24 years and how instrumental he had been. I say that, Dolly Parton sang a song. She said once, I was country before country became country. So, I always say that Dr. Ruffin was addressing health disparities way before it even entered mainstream and really became something that most of us talk about. So I think that was in his honor. We started off by basically having the main lecture series, but also knowing his passion in terms of developing the next generation of providers, researchers. We created this category where we had the junior researcher, John Ruffin lecture. And so we select the best maybe research and have the person present. So this comes out of a competitive selection from the abstracts that are submitted. Yeah.
Excellent, excellent. And then Donna Christensen gave a talk on okay. Donna Christensen gave a great talk as the actual John Ruffin lecture.
Right, yeah. Yeah, that was good, and I think she cataloged, the whole, I guess you could call it the journey of this nation addressing health disparities and some of the challenges. But he also underscored some of the important things that are yet to be addressed. So her talk basically kind of gave us a sense of how much we've come,
Yes.
but yet how much
So
more we
far
have
to
left
go.
to go. Right. So I think in a nutshell, if you had to sum it, but none of these also came without challenges. I mean, there were people in the background who are making these things happen, making these wheels turn. It's almost like, most people watch the movie and they get up and they leave and they don't look at the end where they show the folks who did the lighting, the sound, and it's
The
hundreds of
credits.
people.
Yeah, the
Right, the
credits.
credits, so because we enjoyed the movie and that's it. But there are a lot of folks behind the curtain that makes the movie what it is. So she kind of gave us some insight into that and also shared with us some of the striking data of why we still have ways to go.
Exactly, exactly. So it was a great 2 days. I think you guys did a wonderful job. Next year, if we're lucky, it's going to be in person. Yes, please tell me I get to
Right.
come to New Orleans.
Yeah, you get to come to New Orleans and you get to have a second line and some beignet and not eat
Oh,
too much of the beignet, but just a little bit,
it's a little bit. It's a little bit.
and have a little good time. So we're
Yes,
looking
I can
forward
have some
to
gumbo. Gumbo is really
yeah,
healthy. Gumbo's
yeah, it
good.
is. It
Just not
depends on
so much
how much,
rice, but
right?
gumbo.
Yeah, right, and just eat it good proportions. It's all we need,
That's all you need. That's
I
nice.
would say you can eat whatever you want. You just got to eat in right proportions. Just
Exactly.
it,
Exactly.
it's almost like this. I think sometimes we make certain things complicated. I summed obesity as energy imbalance. So if you're
Yes.
not exercising, you can't eat too much.
Right.
You have to watch certain things you eat. So I think you can have your gumbo, a little beignet, and all that good stuff. Just
Yes.
don't overdo it.
Yeah. Exactly.
And if you
Exactly.
do, you go to the gym in the evening, just work it out.
That's
Work it
right.
off. Yeah.
That's right. That's right. So I'm going to definitely be there whether I'm speaking or not because I just
Uh,
enjoy the camaraderie and all the people there. And there's just so much brain power in that space that for me it's just it's uplifting. So
right.
I try not to miss it. And so I just thank you. I wanted to just thank you for coming on today at last minute, last notice. But we have this recorded. We're going to send it to you so you can send it out, right? Put it up on your YouTube and send it out to all of your alumni and all of the lecturers,
Yeah.
right? So that they can
Right.
also,
Right.
send it out to their constituents and see if we can really make next year an amazing program for you guys. It's already amazing, but I
Right.
just need more people to hear it, right?
Right. Yeah. We have to do a better job in disseminating. I think
Yes.
that's what one of the take-home messages from this. And I think the last presentation for day two was also very powerful, looking at the whole intersectionality of resilience, behavior, and mental health. And really given the genesis of involvement of women in research and how
Right.
policies have changed over the years. So there's a lot that we all need to take time to study and to learn. That, goes back to your point of personal responsibility.
Yeah.
We got to take it upon ourselves to get to know, to be aware of certain things and not expect that the information will automatically come to us.
Yeah. Yeah.
So
Yeah.
I thank you for this opportunity and for being a great supporter of the center and for
Yes.
your work. I mean, you're doing a lot of work with passion, dedication, and making a difference in healing our village. We definitely need a healing, and you're definitely one of the pillars.
Thank you.
Working hard and diligently to heal our village. So we appreciate you. We lift our hats up to you,
Thank you
and we
so
pray
much. I
that you will
appreciate that.
continue to do the great work that you're doing.
Yeah, well, I told you, when I talked to you yesterday, I told you I'm getting tired
Mm.
now, so I need to start passing the
No,
baton. And you told me that 68 is the new 40, so I still got
right,
I
yeah.
still got work to do. So I
Yes, they
thanked
got
you for
work to
that, but I still need to pass the
do.
baton. I
Well,
just
yeah, you
before
can't.
go ahead,
But you still got to be there to coach the folks to
coach.
take the baton, right?
Yeah,
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 to
yeah. I
coach the
can be. I
folks.
always want to be on the side coaching, not necessarily running the
Okay,
race. Okay, that works for me.
okay,
I did want to mention
okay.
something though that you said, a word that I think that we don't think enough about, and that's that word of resilience. The last lecture talked about that. Just think about if we, the people that are now in our communities, our 20-year-olds, our 30-year-olds, people now, and the way we think about things, what if we had have been the slaves? Would we have been able to deal with the trauma and all of the things that were happening to us and still survive and succeed? Those folks had resilience. My mother was resilient. My grandmother and my aunt were resilient. They made it through them 50s and 60s. I mean, it was tough. And so we have got to try to regain, I think, as a people, some of that resilience, so that we can be able to overcome the social determinants of health, overcome poverty, and all of these things, and take the, like you said, the personal responsibility. So, like you broke it down. So, if I'm going to go to New Orleans and I'm going to eat some of the food, then I got to walk around for 30
Yeah.
minutes, 45 minutes to work
Yeah.
that stuff off,
Yeah.
right? Yeah. So it's
Right.
hand in
Right.
hand. So I thank you so much. I'm staying in the fight. I'm gonna stay in the fight. I haven't given up yet. I'm still trying to figure it out. I think technology, which was also talked about at your conference, I think that's the key. So I'm working on
Yeah.
apps, mobile apps. That way we can get rid of the digital divide. We can get rid of the
Right.
fact that we don't have internet and broadband, and people will be able to just see information on their phones. Really simple, easy peasy. So I'm going to hopefully get a research grant. You and I are going to work on getting a research grant.
Definitely. Hopefully, the viewers who hear this presentation, not just this one, but the ones that you've done, will also be able to contribute. Every dollar counts.
Sure. Oh my God.
So even if they could send you $50 in the mail, and if we got 1,000 people to send you, that's enough to do some work. So
Oh my
we got to
goodness.
invest in our own, and we got to invest in what matters.
Yep. We say
Nothing
Black
comes.
Lives Matter. Yeah, Black Lives
Right,
do
so
matter.
we gotta put our money where our mouth is. So
Exactly.
we
Exactly.
gotta be able to not always look for somebody else to give, but we can give. And it doesn't matter how much you give, because the lady that gave her 2 pennies, they said gave the most because she gave all what she had. So
Exactly.
nothing is too small. We
Nothing is
just
too
have to get
small.
in the habit of supporting each other and really contributing to efforts that are yielding benefits so we can multiply, and because it takes resources to do these things. So
Yeah, it does. It does. It does. So
yeah.
for 800-788-0941,
Mm,
that's 800
mm,
788 oh nine four one. My website is hovhealth.com. Up there, we have ways for you to donate. We have a nonprofit for you to donate to as well. So yeah, we really do need as many people to support the efforts. Hit us up on Facebook, Instagram, HOV Health, Healing Our Village. Just Google us, you'll get to us. And Dr. Sarpong, I'm going to bring you back. You know too much. I got to get some more of that knowledge out of your head to our audience
thank,
here.
thank you. I appreciate the opportunity, and I'm greatly humbled and
Oh,
privileged
you're
to, and
wonderful. I
honored
love
to
you.
be in your presence. Thank you.
Oh my God. All right. Thank
Great
you. And
work.
thank you for tuning in today to For Your Health. Come back next Saturday and we have some more good information for you.